Welcome to all of you who are joining us for our webinar on breaking down the barriers to access to antibiotics. And those barriers are particularly high in low and middle income countries, where the burden of antimicrobial resistance is highest. Nearly 1.3 million people die every year from antibiotic resistant infections, more than those from HIV, breast cancer and malaria. My name is Claire Doole and I'm your moderator. And we're going to be hearing about a very exciting first of its kind partnership between the Global Antibiotic Research and Development Programme, known as GardP, the pharmaceutical companies Shionogi and the Clinton Health Access Initiative, CHI. It's a pioneering and ambitious partnership to expand access to a novel antibiotic known as Cefiderocol. We'll be looking at this partnership and its potential to be a pathfinder for access. I'm sure you're going to have an awful lot of questions about this, and we're going to be taking them later on. So do put them in the Q&A box on your screen. And it really helps if you can say who you would like to answer them. And we would also like you to tweet using hashtag #PowerOfAntibiotics or the Twitter handle @GardP. But with no further ado, let's find out more about this partnership from Jennifer Cohn, GardP's Global Access Project Leader. Jennifer, the floor is yours.
Thank you, Claire. And first of all, I just wanted to thank everyone for attending this session. Today, I'll be speaking about breaking down access barriers for antibiotics and really using Cefiderocol as a pathfinder. Next slide, please. So AMR is a leading global health threat. The ability to treat infections underpins much of modern medicine, and if we lose effective antibiotics, we can lose surgery and other critical things that we need to affect modern medicine. The Graham study revealed that the burden of AMR is higher than previously thought, with nearly 1.3 million annual deaths directly attributable to AMR. The global annual death toll is actually higher than other important global health priorities such as HIV and malaria. Critically, most of these deaths are caused by just a handful of pathogens, which opens the door to us actually tackling AMR with improved policies, tools, and practices. The Graham study also showed that the greatest burden of AMR is in low and middle income countries. Next slide, please. Unfortunately, low and middle income countries is actually not where companies are registering novel antibiotics to fight these infections. One study, shown at the graph at left, examined the number of antibiotics registered between 1999 and 2014 and showed that only 10 of the 25 new antibiotics were registered in more than 10 countries, and most of these were in high-income countries. This situation is worsening over time, and the time from availability of a new antibiotic in high-income countries and when it's available in low and middle-income countries may be on the order of years or decades. This is in contrast to the maps at right, which shows the burden of carbapenem-resistant Acinetobacter and Klebsiella, two of the WHO priority pathogens. Where you see red, orange, or light green, these are the areas of higher burden. And you can see we're really seeing a tale of two trends in antibiotic access. We must act now to reverse the growing inequalities in access to antibiotics and ensure novel products get to the regions of highest need. Next slide, please. But to get important new antibiotics from development to patients in need, there are a range of barriers we must address to ensure sustainable, affordable supply and appropriate use. These issues range from ensuring pre- and post-regulatory R&D results in data that can support optimal use across populations and geographies, to supporting and resourcing introduction and implementation plans to ensure antibiotics are used effectively and appropriately. Next slide. So GardP really focuses on late-stage development and access to fill a critical gap in the antibiotic ecosystem. From the start, GardP ensures access considerations are built into development pathways, but we go further. Working in partnership, GardP strives to link innovation with sustainable and appropriate access to products that can treat pathogens on the WHO priorities pathogen list. We focus on serious bacterial infections such as sepsis and sexually transmitted infections. And we really want to ensure that useful products that are in development actually reach patients in need. Next slide. So we've developed 4 access pillars that serve as our North Star for our access work. First, we want to work to be comprehensive. We analyze and identify access challenges across the patient to the product to patient cascade, and we'll partner with a range of actors to reduce or eliminate these barriers. Second, we want to accelerate equitable access so that quality products arrive at the point of care wherever and whenever they are needed. Third, we want to make sure that access is sustainable by supporting appropriate use and stewardship. And fourth, we want to make sure that we're not building parallel systems, but rather working with local partners to integrate new products into existing systems and collaborate to strengthen these systems. Now, the question is, can we actually push ourselves as a community with bold targets across all of these pillars? I won't go through all the potential targets, but for example, can we reduce the gap between when a product is registered and accessible in a high-income country and when it's registered and accessible in a low-income country from potentially decades to less than 5 years? Next slide. Through the Cefiderocol project, GardP, in partnership with Shionogi and Chai, aims to accelerate access to antibiotics for people around the world, especially those in low and middle income countries. The Cefiderocol Access Project is revolutionary and includes a first-of-its-kind license for an antibiotic to treat serious bacterial infections that's provided from a pharmaceutical company to a nonprofit. Next slide. And Cefiderocol is an important antibiotic in that it is active against many of the pathogens on the WHO priority pathogen list. It's already US FDA and EMA approved, and it's on the WHO essential medicines list. However, currently there's no access in low and middle income countries. The license signed between Shionogi and GardP will change that. This license includes a very wide geographic territory, 135 countries, almost 70% of countries in the world. And this includes many of the countries with the very highest burden of antibiotic resistance. And the license also does include a tech transfer from Shionogi. Next slide. So GardP will really use this project as a pathfinder as we create access plans and partnerships for Cefiderocol and other products in our portfolio. But how in practice will this work for Cefiderocol? First, manufacturing. We will work to accelerate quality-assured, affordable, and sustainable supply through access-oriented sub-licensing, which will target the inclusion of provisions for environmental standards, appropriate marketing, and targets for timely registration and commercialization. Next, registration. We need to ensure wide registration for countries in need. We'll also support product approval via the WHO pre-qualification process. And for Cefiderocol and other products, GardP will also help to improve the market in collaboration with Chai by potentially doing things like pooling demand. We'll also need to build evidence to ensure that there's optimal and sustainable use. And this includes across populations, such as for children or across regions which may have different resistant mutation profiles. And finally, we want to make sure that we're actually working with partners to support a phased implementation that includes stewardship and diagnostic strengthening. Across all of this, we'll use the lessons learned, including on stewardship systems, to catalyze appropriate uptake in a wider range of countries. And throughout, we want to work with partners. This is really critical to us. We want to work with partners and focus on building and strengthening a sustainable network for implementation, operational research, surveillance, and ensuring these programs are resourced. Next slide. Finally, GardP is incorporating stewardship into each step of the access pathway. GardP will work to include stewardship provisions and licenses, collaborate with ministries of health and experts to support development of local guidelines, work with local partners for strengthening of diagnostic systems, and incorporate Cefiderocol into stewardship programs. And finally, support for post-approval research can help us actually guide to optimize the use of this antibiotic and other antibiotics. Next slide. So with partner collaboration and support, we can ensure antibiotics are affordable, available, developed for use across populations, including for children and neonates, and are used appropriately to slow or minimize resistance. GardP is honored to be able to work with Shionogi and CHAI, and also partner with governments, organizations, and experts around the world to accelerate access to antibiotics for appropriate use for all those in need. Thank you very much. And Claire, I will hand the floor back to you.
Fantastic. Thank you, Jennifer. And as you say, many companies don't register new antibiotics in these low and middle income countries. And when they do, there's a big gap in the time that they come onto the market compared with high income countries. So we're going to hear from the two other partners in how they're going to narrow that gap. And I'm delighted to first of all give the floor to Gareth Morgan, Head of Global Portfolio Management at the pharmaceutical company Shionogi. Gareth, the floor is yours.
Thank you, Claire, and just some brief comments on Shionogi and how we came to this solution for LMIC access for Cefiderocol. And next slide, please. Well, Cefiderocol is the latest of our antibiotics, but Shionogi's got a long history in the infectious disease space, going all the way back actually to 1959 and sulfamethoxazole, which is interestingly still in use today. A number of other important antibiotics, I think, along the way: moxilactam, flumoxif, ceftibuten, cefticapine, doropenem, to name some of the more important ones. Shionogi is also active in the antiviral space, and you can see here dolutegravir, which is discovered by Shionogi, of course marketed in much of the world by ViiV today. Baloxavir for influenza, and we are active in the COVID space as well. We are very committed to providing appropriate access for Cefiderocol, and with that in mind, what set out to find some partners to help us. Of course, providing access in low and middle income countries is really quite a complex undertaking. We have to deal with local regulations, pharmacovigilance and safety reporting challenges, manufacturing and supply chain challenges, and of course we want to ensure appropriate use so that these new antibiotics really can retain their efficacy over a long period of time. So with that in mind, we did set out to identify appropriate partners, and next slide please. We went through a pretty comprehensive evaluation process. We came up with GardP and CHAI as providing very complementary skill sets, and skill sets that, along with those that Shionogi brings to the table, we feel will set this collaboration up for success. I've listed here some of the skills that the different organizations bring to the table. And next slide, please. So again, sort of thinking through the expertise and experience that the three partners here have, we're very comfortable that this collaboration is going to be successful in delivering on access goals. We did go through a process of working together to lead up to June 15th signing of the license and collaboration agreements. You can see here a picture from the signing ceremony that occurred in Tokyo just a few weeks ago. But I do just want to finish by saying that Shionogi is going to stay involved. So this is not an instance where we'll just sign an agreement and sort of back off. We want to stay involved. Shionogi is really, I'd say, one of our babies. We've invested a huge amount of time and money in developing it, and we want to make sure that patients around the world can benefit from Cefiderocol. So very much looking forward to working with GardP and CHAI to create a situation for appropriate access. And with that, Claire, I'm going to hand back to you.
Well, thank you. Good to know that you are committed to this very exciting collaboration. So let's bring in the other partner, Dave Ripin, Executive Vice President of Infectious Diseases and the Chief Science Officer at the Clinton Health Access Initiative. Dave, the floor is yours.
Thank you, Claire. I just want to start by saying how excited we as CHAI are to be a part of this collaboration. CHAI's approach in the space of bacterial AMR is fundamentally to expand the appropriate and correct diagnosis of bacterial infections, beginning at the community level and escalating to the hospital level. And ensure that the financial incentives, including the cost of diagnostics and treatments, reinforce the appropriate use across all lines of therapy. Shionogi's decision to license Cefiderocol has created an exciting opportunity for this collaboration to work to ensure timely access to a later line treatment option for patients with severe infections in countries that, as you have heard, would typically lag in gaining access to an exciting new product like this. CHAI has a track record of working with innovators, generic companies, and national treatment programs to accelerate the delivery of quality products across low middle income countries at affordable prices. And as such, we expect to drive a couple of key aspects of this collaboration, including supporting selection and then driving the technology transfer to the selected generic manufacturing partner for this licensing agreement. And secondly, working at the country national level, using market shaping strategies to create access to Cefiderocol in a manner that's economically aligned to its appropriate use. We're really excited about bringing this unique model of partnership to the antibiotic development and access space, and firmly believe that partnerships like this are critical to making appropriate diagnosis and treatment of bacterial infections from the community level to the hospital level more accessible in low middle income countries. With that, I'd like to thank you all. Look forward to your questions and turn it back over to Claire.
Thank you very, very much, Dave. And we will now go to the panel discussion, but please stay with us because I'm sure you might want to respond to what our speakers is going to say. They're all experts in AMR and also would really like to encourage the audience. I always used to say as a former journalist, there's no such thing as a stupid question. So if there's something that you really want explained about this unique partnership and collaboration, please ask it. So we've got 3 other AMR experts with us, and I'm delighted to introduce Mirfin Mpundu, Director of REACT Africa. Mirfin has been working for many, many years in the area of AMR, and he's been helping a lot of African countries with their research and national action plans. We also have with us Kamini Walia, who's a Senior Scientist and Program Officer for AMR at the Indian Council of Medical Research. So welcome. And we have Jeremy Knox, who's Head of Policy, Infectious Diseases at the Wellcome Trust, which many of you will know is a charitable fund focusing on health research. And it's got a dedicated program on AMR, which focuses on key research gaps and policy. So you will have heard our speakers at the beginning perhaps talk about some of the issues around access. And we're going to call these the 3 A's and talk about appropriate and responsible use, sometimes referred to as stewardship, availability, as in manufacturing and distribution, and of course, the big one, affordability. But before we get into the issues, I'm going to ask our speakers briefly to tell us about the benefits from their perspective that they see of this partnership. Let me begin with you, Kamini, because I understand that India may be one of the countries in the first wave to benefit from this partnership. What difference could it make to patients in India?
Thank you, Claire. And you very rightly brought out the factors that actually influence the excess of any antimicrobial in the low middle income country settings, which is the affordability, the availability. So India has a huge burden of gram-negative infections. And we are also now finding it challenging to treat those drug-resistant infections, especially the gram-negative pathogens. The new drugs or new antimicrobials or treatment strategies are really the need of the hour. We urgently need new treatment solutions for our patients. So in that context, I think this drug is very, very important. And we have been looking up to this drug as to when it is going to hit Indian shores and when will it be available for our patients. So this particular collaboration, I would say, fills a very important gap over there, because Chai is a known partner in this space of making the treatments accessible from the previous their experience of working in India as well. And GardP has a focus on AMR. So in that context, I think this collaboration augurs very well to the needs of India for AMR.
Yeah, absolutely. Where, as you say, you've got a lot of burden of what they call the gram-negative bacteria, this bacteria which is resistant to other antibiotics. Mirfin, how do you see low and middle income countries in Africa benefiting from this partnership? I think South Africa might be in the first wave, but just a few quick thoughts, even though I know that Africa is a very big continent, so difficult to make generalizations.
Thank you so much. Just to build on to, this is a great collaboration and a great effort, and congratulations really for this. The Cefiderocol is very effective, as Kamini has said, against some gram-negative, pathogens, which are very stubborn. And living in Africa, in Sub-Saharan Africa, we've got the highest burden of infectious diseases, and gram-negative actually sepsis is a major challenge. And so we're going to benefit in patient outcomes, reducing morbidity, and be able to actually use these antibiotics hopefully appropriately. The second area that I think is important is that this collaboration brings in a huge number of licensing territories. And so under this agreement, really GardP, Shionogi, and Chai will manufacture and commercialize actually this new molecule, Cefiderocol, through the sub-licenses in a large range of countries that have delayed access to newer and old antibiotics. And so the licensed territories really are quite comprehensive, as they include low and middle income countries, where actually challenges are in terms of manufacturing. Another area I see African manufacturer benefit, it's beyond sub-licensing in technology transfer and capacity building. That will be a great benefit, because one of the solutions, we really have to look at the challenges of access in low and middle income countries is around local manufacturing, because we import over 90% of our pharmaceutical needs. And so I think this will be able to, to catalyze manufacturing in African countries with building capacity, technology, and being able to meet the challenges of access, affordability that we face. Thank you.
Yeah, and we'll have a look at one of those A's, the availability, in a moment. Jeremy, we've heard India, South Africa, the LMICs, the low and middle income countries in Africa, all very, very keen to get this antibiotic on the market. But of course, it's not just LMICs, there's also high income countries that are benefiting from this. A couple of words from you.
Yeah, thanks, Claire. So I think the other panelists so far have really set out why this is such a groundbreaking step forward and why it's so important globally that we have this partnership, essentially establishing a template, a pilot, if you like, for how we can establish access in new ways and forge new partnerships between the private sector and other sectors to try and kind of break down some of those barriers to access and close that gap between high-income country introduction and low-income country introduction that Jennifer described at the start. I think it's not a question of this deal bringing benefits to high-income countries per se. That's rightly not the focus here. But I think there is a key point here around actually access to antibiotics being a universal issue that cuts across high-income countries as well as low-income countries. We're already seeing that in kind of many high-income settings, particularly small countries, there are real issues with antibiotics not being registered in those countries. And clearly the dynamics of the problem are different there. The ability of those governments to solve the problem of access themselves is completely different to low middle income settings. But I think there is a kind of really key point here, but we need to be thinking innovatively about access to antibiotics, about how to create stable, attractive routes to market in all sorts of settings for antibiotics through kind of proactive government solutions, as well as these sorts of partnerships between industry and non-industry partners.
Thank you, all of our speakers, for outlining the benefits there. Now let's have a look at our 3 A's. First of all, appropriate and responsible use, because of course there's always a risk that a new antibiotic comes onto the market and doctors start to prescribe it perhaps for the wrong reasons, or they overuse it. So they've got to be good stewards. Jeremy, where do you see the challenge, and what really needs to be done to ensure that this new antibiotic is appropriately and responsibly used?
So I think you rightly picked up here. This is going to really be a key challenge here for GardP, for CHAI, and for Shionogi as delivery partners on this. And we heard from Dave from CHAI talking about how his organisation has a history of working with local partners, governments, health systems, clinicians, to try and address these sorts of issues around how drugs are accessed and used in low middle income settings. Ultimately, I think that the challenge of low middle income country access to antibiotics, unlike other areas, other kind of therapeutic categories, this isn't simply a question of volume and trying to solve access issues by getting innovative drugs into countries in as large a volumes as possible. We need to be making sure that they're used in an appropriate way, in a sparing way, and giving access to patients who need them, but really making sure that we're identifying those patients who need them and who can't be treated with other alternatives that might be available. And really, that's a big challenge. That requires some, again, innovative solutions to address. It depends ultimately on being able to ensure that we're giving local clinicians, the people who are making the prescribing decisions and are responsible for making sure these drugs get to patients, that they're given the tools, the capabilities, the support they need to make the right decisions, to be able to identify the patients that needs Cefiderocol compared to other antibiotics, and that it's being used in a timely and appropriate way. Make no mistake, that's a significant challenge, and a lot of it hinges on really the availability of things like diagnostics or good laboratory capacity. They're big challenges that we know need to be addressed in the broadest sense. But I think it's vital that we now start to look with this pilot, with this program, of how we can start breaking down those barriers and ensuring that we give as wider access as possible to this innovative drug. But at the same time, be careful that we're not overusing and misusing it.
Yes, as I think Jennifer said, you need to strengthen diagnostics so that doctors can prescribe the right antibiotics, the right treatment for the right patient. Kamini, this issue of stewardship, you know, it is an issue, isn't it, in India? It is a risk. Any thoughts, any advice that you might want to give the partners on how to make sure that they get it right and there's good stewardship when this drug is rolled out in India?
Thank you. So 2 issues are very important here. One issue has been raised by the previous speakers, that is improving the diagnostic stewardship, so that we can reduce the misuse and the overuse of antimicrobials. But one very important aspect is the improper infection control practices. Most of the in low middle income countries, actually, since the IPC practices in hospitals as well as the sanitation hygiene in the community is so compromised that most of the time we are using these antimicrobials to cover for poor sanitation and hygiene practices. So there are two major components to improving the use or specificity of use of antimicrobials, which is improving the diagnosis and reducing the use to cover for poor IPC. Now, diagnostic stewardship requires a whole the infrastructure of laboratories, the availability of microbiologists, and IPC also is a very resource-intensive exercise, and so is antimicrobial stewardship. No wonder we see all of these as major challenges in implementing the overall stewardship around antimicrobials. So it has to be, it is a long, a long battle, I would say, that we are all fighting. And but yes, there are two very important components to improving stewardship: strengthening the hospitals and creating education and awareness in the community. Now, this particular drug, Cefiderocol, is a injectable drug. So in all likelihood, it will be used in hospital settings. And there is an opportunity to kind of engage with the doctors, do the education and awareness around this drug. And not just this drug, many other injectable drugs will also benefit from improving the antimicrobial stewardship practices. In India, we have been working with tertiary care hospitals to improve the AMSP component of those hospitals, and we have been successful to an extent that we have been able to set up the structure and framework of AMSP in hospitals where none existed. Then a regulator also, I think, has a very important role to play here. The regulatory stewardship. How are you going to place a new drug within the existing healthcare system, and how its sale is going to be regulated? India has one H1 schedule in which some of the drugs cannot be sold without prescription. So there is no doubt that this particular drug will go in the same basket. And then implementation in a big and diverse country like India, there are challenges around it, but then there is also more awareness around these issues now. But yes, it's a work in progress, and it will have to continue with full vigor and support.
Yeah, Kamini, yes, we can see that as you and Jeremy have been mentioning, appropriate use is a big issue. Mirfin, do you have any thoughts for the partners on how they should make sure that it is responsibly and appropriately used? Who should it be rolled out to, and under what conditions?
Yeah, I think that, yeah, just building on to what Jeremy and Kamini have said, this is a great opportune moment and time. And I think the way we roll out this new molecule, Cefiderocol, would be a proxy to strengthening health systems, but also to ensuring actually correct antimicrobial stewardship, actually works. We don't want to lose it very fast, the way we have lost so many antibiotics, including ceftriaxone, where we are seeing lots of resistance. And so there has to be a cautious actually system in introducing this drug in new markets in our countries and in my own country where I stay. And so that, there have to be the capabilities and capacity of actually being able to monitor our basic way to actually, this rollout, that's very deliberate. The way, for example, they did in India with the release of bedaquiline, they had a conditional access program, and that program has been successful. So it should be rolled out in select institutions that have got the capacity and capabilities. The lab infrastructure must be in place. They should be able to identify, which pathogens that would respond to this new molecule. And secondly, we have to be able to have actually guidelines in place. Those guidelines, clinicians have to adhere to them. We have to build actually capacity in institutions. We have to ensure that, this drug is in the national essentials medicine list at country level, but also in the hospital formularies. There will be a number of components that need to work together. And so that again, on the issue of regulations, we have to ensure that really our regulators don't allow the situation we currently have now, where you can buy both injectable antibiotics or oral antibiotics without a prescription. So this has to be really guarded against by pulling together and ensuring we have a system that will allow this drug to be used appropriately for patients who need it at the right time in the right quantities. Otherwise, we're going to lose it very fast.
Mirfin, you make that very, very clear. So appropriate use, we've seen it's a work in progress. Let's move to availability. And Mirfin, you were mentioning that in your opening remarks, and I can see that you've looked in detail at this collaboration and license agreement, the secondary license agreement. I mean, what do you think needs to be in place for Africa to be able to manufacture this antibiotic and make sure that it's quality assured?
Yeah, it's very heartbreaking so many times, Claire, to walk into a country and get into institutions and the basic antibiotics are not in the health facilities. We're losing too many lives, and and we talk about the current ones before even we move into Cefiderocol. And so, one of the things that is very key to assure that there is this availability and this quality, we need to build a workforce in disciplines for local manufacturing. That's critical for us to do. And this collaboration, at least one of the elements that they've included is the technology transfer and the willingness to be able to invest and work with local manufacturers in different countries. We have to ensure that we adhere to good manufacturing practices and that the regulators are equally capacitated and strengthened. We have to ensure that there's transparency in the global supply chains and actually increase production capacity for procurement. We have to ensure, which I also like in the license has been picked up, the issue around manufacturing and diversification of the active the APIs, active pharmaceutical ingredients, because currently what we have is that there are few countries that manufacture APIs, the critical ingredients in an antibiotic, and this will be diversified. It's a great opportunity for our local African manufacturers to do that, because when you depend on, over 90% importation, if there's any disruption like we saw with COVID, you are absolutely really on your own, and there are few things that you can do. But we also have to strengthen our data systems to collect the data and to feed back to actually Shionogi Chai and GardP to ensure that we're learning from that, what we are seeing, and strengthening our systems as we go forward.
Understood. I was just going to pick up, of course, on APIs. India, of course, is well known as a manufacturer of APIs and generic drug production. And I'm just wondering, Kamini, what do you think it would take for this antibiotic to be sufficiently attractive to Indian manufacturers? Are they all going to say, yes, please? Or are the partners going to have to persuade them in any way?
So India has been one of the hubs for manufacturing pharmaceutical agents and the drugs in India. It's a number 3rd in the list, I think, and India and China basically. And India has been also sometimes referred to as the pharmacy of the world. So Indian drug companies are into generics and they pick it up very easily, provided they know the product is good, it is efficacious, and there is going to be demand of this particular product. With infectives, things are very different, because when we don't regulate the use of antimicrobials, they lose their life very fast, and within a matter of few years, nobody needs that product anymore, not just in India, but outside as well. So all this discussion, I think, where we are talking about having good diagnostic stewardship, good antimicrobial stewardship, as to how we can rationalize the use so that you extend the life of a product. This is going to go a long way in kind of, inspiring that confidence among the industry that, okay, they are going to make some money out of it, and, they should be going into it. As previously pointed out, there is a long gap between when a drug is introduced in US or in other Western markets and when it actually hits India. So the reason is partly the same. It's an overlapping reason that you don't see many companies making an application to DCGI. Or the Drugs Controller General of India, who regulates the approval to drugs. So that's the reason that, if we bring, if there is a technology transfer, as Mirfin has pointed out repeatedly, that one of the huge bright spots in this particular collaboration is technology transfer. So if we are able to bring technology to India, it is going to also improve affordability of the drugs, because it is cheaper to manufacture the same drug in India as it is when you manufacture elsewhere in the world. So all these factors cumulatively, I think, will be instrumental in kind of mobilizing Indian generic manufacturers to go in and pick up this product and express their interest in participating in this particular activity.
Thank you, Kamini. And of course, you mentioned the word money. And we come on to the last A, affordability. Jeremy, perhaps I might bring you into the discussion. You might want to say something about manufacturing, but I know that you've also been working on affordability. You've been working on some pricing models in the UK National Health Service with Shionogi, I understand. So, I mean, from a drug company's perspective, what sort of financial incentives do they need, do you think, to register a drug like this one, and we hope other drugs in low and middle income countries?
So I think we see a pervasive problem with antibiotics in high-income countries, low and middle-income countries alike, in terms of the attractiveness of markets, and that comes down to prices are generally low and volumes are very low and unpredictable, and it's difficult to establish a kind of strong commercial proposition to take a drug into any market where you can't be sure of the level of revenue and whether that revenue will cover the costs, even of being on market, let alone the costs of R&D. So we've seen a lot of conversations in the AMR space around these Netflix models, the idea of paying for antibiotics rather than on a pill-by-pill basis, but actually paying for access on an annual or kind of multi-year basis, as you pay for Netflix, rather than paying per film or per TV program. You pay a monthly subscription, and I think that has real advantages in the antibiotics market and can provide some real certainty. I think we've seen so far that the interest in these models has been concentrated in high-income settings. You alluded to I think the UK, where the English National Health Service is running a pilot, again, which Shionogi, I understand, is a partner to try and purchase antibiotics in this way. We've seen a similar model in Sweden, where the issue there is not about trying to incentivize R&D, but it's about trying to make sure that in a small but affluent country where they have very low rates of AMR, but still want to have availability of antibiotics, they recognize they need to take new ways to pay for antibiotics that don't depend on volume and don't depend on sky-high prices. So I think there's a kind of couple of lessons we can take from this when we're thinking about the bigger picture and thinking about what's needed in low and middle income countries, or how to address the challenges faced by low and middle income countries. I think the first thing is around the availability and really trying to solve the innovation conundrum is the first thing that needs to be done to address access problems globally. We can only start addressing access problems if we have a strong pipeline of antibiotics, and if we start putting the antibiotics R&D ecosystem on a more stable footing. And these sorts of reimbursement models, I think, make investments in antibiotic R&D more attractive for all sorts of investors. So that will help us ensure we have a stronger pipeline going forward. I think the second thing I'd say is we need to start thinking about how we can use these types of models in middle-income countries and those sorts of markets where actually we do have very strong and kind of ever stronger healthcare systems and governments that are playing a kind of very strong and active role in those healthcare systems. I think there's a need to think about, well, how can we adapt these models to actually make sure that we don't make prices excessive for novel antibiotics, we don't create issues of affordability or kind of access barriers that way, but actually how can we kind of harness the role of governments or health systems as market makers, as purchasers of antibiotics, to kind of make these kind of middle-income countries sustainable and attractive places in which to bring an antibiotic to market as a priority. That's work we've been exploring at Wellcome. We're supporting a think tank called the Centre for Global Development to try and advance that conversation and try and advance that thinking. And I think it's a really important next step in terms of where we, the AMR community, have been thinking about R&D and access so far, which has been a bit too focused, I think, on high-income settings.
Interesting. And I'm going to bring back in a moment to the partners and take some of the questions that are coming in from the audience. But let me ask you all, just to be very brief, Mirfin, how could you think this partnership could open up new pathways? How scalable is it? Very, very briefly, Mirfin, Kamini and Jeremy, and then we'll take some audience questions. Mirfin.
Yeah, it is actually scalable. I think there are great opportunities. I think through partnerships and the transparency, we have actually the agreement that is transparent. Everybody can read it and the commitments that are being made. And it is actually taking the highest public health needs, because it looks at the priority pathogens by WHO and targets, uses that to target, drug development. And so, we will be focusing on priority pathogens, so there will be a great benefit. But also just quickly to mention that, in ensuring sustainable access, the partners will need to look at, our food procurement mechanisms as one of the ways that we can actually ensure sustainable access, but also look at the issues of affordability and pricing, because in most of our countries, out-of-pocket expenditures are the #1 ways of paying for healthcare. And so the insurance the schemes are just coming into place, and the governments have been cutting funding in healthcare over the last 15 to 20 years. And so, this would be very critical to see how are we going to position Cefiderocol and use it really as a great model to actually roll out a drug that is affordable in Chad, affordable in Togo, affordable in the UK, and it is being used appropriately. Thank you.
Understood. Kamini, very briefly, Mirfin says scalable, but of course there's the affordability and the pricing issue. Kamini, what are your thoughts? What would you like to see happen?
As all the previous speakers have pointed out, that this particular drug and this particular collaboration addresses a very important area, very important public health challenge. And there has been good amount of sensitization and awareness around the need for new treatment solutions. So in that context, I think in India, at least, all the 3 partners who are coming together, ICMR has a MOU with GardP, and GardP working with Shionogi and Chai, and all the 4 partners coming together. I think it's a huge opportunity to kind of create a new model. I think everyone would be willing to put in their skin into the game to see that, this particular thing is successful, because this is an opportunity that we can't afford to lose. This opportunity promises new drugs. It promises shorter time to introduction. So I think everyone stands to gain from here. And if we lose this opportunity, I don't know when will we test a new model of translational research like this. So that's why I do have a lot of hope from this particular collaboration in terms of achieving what we really have set out to achieve.
Yeah, understood. And I can hear, Jeremy, you're nodding along with what our speakers have said. anything briefly to add about how you see this partnership opening up new pathways? And then I have got some audience questions that are coming in.
Yeah, I absolutely agree with Mirfin and what Kamini has said as well. I mean, I think this has to be a big first step in terms of a scalable model for antibiotics. When we look at other areas of global health, things like HIV, things like malaria, in the past 10, 15, 20 years, we've made massive progress in addressing the access gaps that used to exist on kind of unconscionable scale in low middle income countries. And that's been thanks to having the right combination of innovative public-private partnerships, the right funding and the right political will. This is the first step, I think, in trying to kind of crack the big problem we have in access to affordable, innovative antibiotics. I think we just need to kind of make sure that we're using this opportunity to really start kind of bringing those success factors that have been used in other areas to the issue of antibiotics. But the problems may not be exactly the same, but I think ultimately it requires the same sorts of innovative, sustained solutions.
Thank you. So let's move to the question and answer. And I'd very much like to bring back Gareth Morgan, Head of Global Portfolio Management at Shionogi, Jennifer Cohn, GardP's Global Access Leader, and Dave Ripin from the Clinton Health Access Initiative. So there's a question here, Dave, for you. It says, congratulations on this wonderful initiative. An issue in low and middle income countries is delay in detection of resistance. Yes, we've been talking about this. What could be done to provide access to rapid diagnostics in a similar way? Dave.
It's a big question, so I'll try to be brief. I mean, I think, and fundamentally, I emphasize that we believe that addressing AMR needs to start on the front lines at the community level when individuals are first feeling ill, even though the vast majority of them do not have a resistant infection at the beginning. And I think we really need to put stewardship into terms that patients and providers see as in their best interest. I want a correct diagnosis as soon as possible, and I want the correct treatment. That includes figuring out what infection I have and to what antibiotics will it respond, and to what antibiotics is it resistant. That may or may not happen at the very first visit, but we have a set of donors who have invested a huge amount in diagnostic systems looking at disease surveillance. We're not effectively and sufficiently using those advanced tools to make patient level diagnoses and treatment decisions. And I think there's an economic opportunity there. If you start treatment at the community level, you're going to do it with a diagnosis which is either empiric or uses a rapid diagnostic test. And there's only so many of those you can run in sequence. So we need to think about what suspicions or questions will clinicians have. Which ones of those can be answered with a rapid test diagnostic immediately, and which antibiotics should we have at the community level on the basis of the data that those diagnostics can provide. I definitely believe there's a role for rapid diagnostics at the community level, but we're not going to diagnose every infection and every resistance pattern only using rapid diagnostic tools. So I think we need to be very smart about combining the use of rapid diagnostics with a centralized lab and collect samples accordingly.
Thank you. A question here, Jeremy, for you. We know we need more public and private investments to develop new antibiotics to treat drug-resistant infections. What do you think is the most convincing argument to generate greater investments from both governments and the private investors? There we are. We need a campaign. We need, it to reach the public consciousness, the face of AMR. Jeremy.
I mean, I've been trying to answer that question for several years now. I think a lot of us on this call have. So I think if any of us knew the answer, we'd be putting ourselves out of the job. I think, I mean, the numbers that Jennifer presented at the start, the numbers from the Graham study, which Wellcome supported and was published at the start of the year, I think they speak for themselves in terms of the burden, in terms of the challenge here. When it comes to the specifics of trying to support antibiotic innovation, I think we really need to be clear that this is a big crisis. It's only getting worse. It's only going in one direction. We're already starting to see people dying in unacceptable numbers for lack of treatment options. And this is something which we can innovate our way out of. We know that when you have a combination of sustained funding and political will and support for R&D, more often than not, we find our way kind of to bring new products and to find innovative solutions to these problems. So governments love innovation as something that they can support, something that they can champion. And really, this is an area, as we've seen with COVID over the past couple of years, where really innovation and support for innovation is going to be key to ultimate success.
There we are. I can see there's lots of people nodding here, and Dave put up his hand and then Gareth. So let's go first to Dave. Thank you for this question. It's obviously provoking a lot of thought about the most convincing argument. Dave and then Gareth.
I mean, we're seeing a lot of investors and donors step up and put a lot of money into innovating and developing new products. We've seen companies like Shionogi, company collaboratives like the AMR Access Initiative, donors like the Wellcome Trust, public donors like ICMR supporting the development of new technologies and new science. They're delivering products into a vacuum. We don't have a global fund for bacterial infections as we do for HIV, TB, and malaria. And as long as that's the case, we can continue to innovate, but those innovations are not going to be as quickly, rapidly, and appropriately used in the marketplace as we want. So I see a major vacuum there where we need investment to complement the investment that's being made, both in developing new technologies and running the surveillance systems to watch this emergency unfold before our eyes.
Yeah, it needs a home for AMR. Gareth, your thoughts?
Yeah, thank you. I'd sort of like to draw the analogy back to COVID, and you know, certainly it's an infectious disease that caught the world by surprise, has cost a tremendous amount in terms of lives and money. But you know, AMR is really the silent pandemic. I think some of us call it the silent pandemic. We know it's coming. We should not be caught by surprise with respect to AMR. So we do need the world to sort of recognize that actually AMR needs the same kind of attention that we've been giving to COVID.
Kamini, you had your hand up, and then Jen.
Yes. So this is regarding the discussion we are having, which Dave pointed out, that, you know, we are delivering products in the vacuum. I can't agree more with him. Whether it is diagnostics, whether it is new antimicrobials, Indian innovation scene is looking very vibrant. There are so many startups, there are so many you know, small companies who are investing in developing diagnostics. We followed 8 diagnostics for 2 years, and we realized they haven't reached anywhere closer to the regulatory approval or to even inclusion in the national health system. Sadly, all these efforts were supported by Government of India by one instrument or the other. So, I mean, what is important is that we create pathways. We create pathways and frameworks so that we are able to translate these products into real public health gains. And that's what is missing, not just in India, I thought globally as well. There's a lot of work that can be done around it. And only then we will be able to get more affordable products, quality and affordable products, if we invest in this space, in the translational research as well.
Jennifer, I'll give you the floor. Then there's lots of other questions coming in, so I'd like to direct those to other people. Jen.
I'll be very brief. I just to say I absolutely agree with Gareth about the parallels between AMR and pandemic preparedness and response. AMR is a pandemic. It's implicated even in viral pandemics, and the number of the same market forces as well as enabling and preparedness pieces are the same. We need surveillance, we need diagnostic systems, we need rapid response, and we need keep warm technologies, even in the interim between pandemics or while we're waiting for the inevitable to happen, which is for antibacteria to develop extensive resistance.
Jennifer, another, of course, this is the big question. As a proxy for understanding the implementation challenges, registration, marketing, product stewardship, how long before we see the availability of this product? When is it going to be in the market, at least in these first wave countries? Can you give us a time frame?
Question, and I think, you know, I will presume to speak for my colleagues at Shionogi, appraised of this process, but it is a process. We need to identify a quality manufacturer who has the capacity to produce a quality assured product, to potentially distribute the product. We may need additional commercial partners. That manufacturer will need time to actually receive the tech transfer, develop the product. But what we want to do is actually overlap certain activities. So we're not just sitting and waiting while the product is developed. We want to do the regulatory landscape, and we want to work with national regulators to see what pathways we can work on. We want to work with ministries of health and other experts to see what are the pathways for introduction, how can we identify and strengthen the diagnostic systems, stewardship systems, as well as what are the guideline changes or even, you know, fundraising and kind of budgeting needs that we can put in place now so that Cefiderocol and other products have a glide path to go down once they actually hit the market. And I see Dave has his hand up as well. Sorry, yes, I didn't mean to presume to.
Yeah, I mean, I can't specifically answer that question, but there was also the comment, will generics say yes, please? We are asking companies to develop a product that ultimately we want to use as little as possible in markets which can afford the drug the least. And so we may have to financially share the risk with those companies, and doing so gives a donor, gives a partnership a level of control and insight into timeline to ensure that that timeline is adhered to and delivered against. Otherwise, we're asking companies to prioritize a product that will be used very, very little in a portfolio against products which they may be choosing to develop, which will see a much larger market. So I think there's a role here for donors to step up. I don't think it would be that expensive, but it would give us some level of control and acceleration in ensuring the product is ultimately delivered into these markets.
Well, we are, of course, at the last moment, and it is already 3 o'clock here in Geneva. Our hour is up. We're getting so many questions, but I will perhaps end, as we unfortunately must, with a comment from a participant who says, if we are able to restrict the access to antibiotics by ordinary people here and there in LMICs, half of the job is done. Selection pressure will be reduced. Eventually, it will be easy to reduce the burden of AMR. Well, I'm not sure whether this collaboration or partnership is easy, but I think everybody is very excited about it. And I would like to thank our speakers for giving their insight on how to really roll it out and make sure that we do overcome the barriers to access to this particular antibiotic and other antibiotics. I'm sure there will be many more webinars and many more questions as this partnership is rolled out. So from me, Claire Doole in Geneva, and all of our speakers from around the world, thank you so much for joining us.
Thank you.
Thank you.